Good morning, everyone. I have a few housekeeping announcements. Yesterday, it was a little busy. We had some IT problems. So please, I'm going to ask the speakers to respect the time of 20 minutes. And any assistance, the team is ready to help you. So we'll start right away. Our first speaker today, it's an honor to introduce her, Professor Sheila Miyatra. She's a professor of anesthesiology and critical care medicine working at the Tata Memorial Hospital in Mumbai, India. She's the chair of the Intensive and Critical Care Medicine Committee of the World Federation of Societies of Anesthesiologists, WFSA, and the immediate president of the Indian Society of the Critical Care Medicine. She is the past president of All India Difficult Airway Association. I never knew that there is an association for difficult airway, which is the topic of her discussion, and she is on the editorial board of several journals. So this morning, in line with the difficult intubation thing, she will be talking to us about intubation in ICU. Is it life-saving or life-threatening? Dr. Sheila.
Good morning, everyone. It's nice to see. I was not expecting people to turn up so early, but it's nice to see at least a couple of people here. I bring you greetings from Tata Memorial Hospital in Mumbai, where I work. And I'm really, really very delighted. It's my first visit to Kuwait and to come to your beautiful city. And at the outset, I'd like to thank the Pan-Arab Critical Care Medicine Society and the World Federation for giving me this opportunity to speak at this meeting. Now, the title is a little provocative, life-saving or life-threatening, and you'll see in a minute why I have chosen this title. Now, I'll start with a case scenario. 57-year-old male, acute hypoxemic respiratory failure. He's come on BiPAP, low SATs, and of course, an airway exam is not possible, and you're planning to intubate this patient. Okay, so I've given this patient propofol, suxamethonium, I use a video laryngoscope, pass the endotracheal tube under vision through the cords, and I see a nice waveform Kaplan-Meier trace. Excellent, I'm good to go. I'm really happy. I move to the next patient. And the tube went in, but my patient just collapsed. Right? The patient's next blood pressure is 80/40, end-tidal CO2 drops. I give mefentamine, you may give another drug, and the patient becomes pulseless and CPR is begun. Of course, it may not be so dramatic, but I'm sure you often see hypotension in these patients. Now, this patient has what we call a physiologically difficult airway. And this term was first coined by Professor John Sackles. And subsequently, this is an emerging concept. And we've developed on this, and we've got global consensus on what the physiologically difficult airway is. Now, I want to introduce this entity to you, because we are really obsessed with anatomically difficult airway. All kinds of tests to get the tube in. The obsession is to get the tube in, and we're always thinking about complications related to not getting the tube in and losing the airway. However, the physiologically difficult airway is about physiological and pathophysiological alterations that increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. And very recently in intensive care medicine, we just published in October this global Delphi among leaders in the field of airway management in critical care to get consensus on various interventions for the management of this entity, the physiologically difficult airway with tracheal intubation in the intensive care unit, where the evidence is weak or actually absent in some of the areas. And I really urge you to read this paper that was published in intensive care, and we've given some very nice graphics and summarized the findings. And of course, in this talk, I'll just be giving you an overview because I just have a few minutes. But I really urge you to read this paper because there's some useful information out there. But in summary, we've expanded this definition to just from the intensive care unit to both physiological and pathophysiological alterations in the patient that increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. So it could be even physiological conditions like obesity, pregnancy, you know that they are high risk, they have a short apnea time, and they can rapidly desaturate when you try to intubate them, and various physiological alterations that you see, especially in the critically ill patient, that can increase the risk of complications. So the definition of a physiologically difficult airway is one in which the patient's physiological or pathophysiological alterations increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. And I've already described the contributing factors to you. So you may all know this study, the Intube study, which we published in JAMA, and I was really honored to be the second author of this paper with Professor Vincenzo Russotto from Italy. And this was the first real-world study, global study, where we looked at how were people intubating critically ill patients and what were the complications associated with tracheal intubation in the intensive care unit. Until now we had national audits or single center studies, mostly from the developed world, and we had very little data from the developing world. And as you can see, this was a study, it was an observational study, of course, 5 continents, almost 3,000 patients, and a large number from the developing world. Now, I'll just give you a little overview of the study. We looked at, the primary endpoint was looking at least one of these events occurring within 30 minutes, severe hypoxia, cardiac arrest, or cardiovascular instability. And just the important findings of the study. Now, if you look at a complication occurring after tracheal intubation, which is our primary endpoint, it was 45%. That means almost 1 in 2 patients who you intubate in ICU actually have a complication. Now, most of the time, we think this is hypoxia, but what this study showed, that it is not hypoxia, but it is hypotension that is the most common occurrence, 42%. Again, almost 1 in 2, and hypoxia is 9.3%. Perhaps over time, because we've been really worried about hypoxia, we've become very good at peri-intubation oxygenation. And it's the hypotension that is the most common occurrence that we're probably missing. And an important finding of this study that's not actually been shown in any of the airway management papers in critically ill is that if your patient experiences an overall outcome of cardiovascular instability or cardiac arrest, they had a higher risk of a 28-day mortality. So sometimes you have this complication, hypotension, hypoxia, you give some vasopressor, the blood pressure comes up, and you don't really worry about it because this is just a short interval. But this complication that you have during tracheal intubation actually has a bearing on your 28-day mortality. So it's not something that you can take lightly. So rather than treat it, you should do something to prevent these kind of complications. Now, I'm an anesthesiologist and I work in critical care, but I do spend about 20% of my time in the operating room. And I've always wondered, why are complications related to tracheal intubation and critically ill higher than in the operating room, right? Because I have the opportunity of being in both the locations at the same period of time. And in my mind, there are 3 fundamental differences. One is the ICU environment. You just look at the environment, how complex it is. Just getting to the head end of the bed is just a struggle. For those who work in the operating room, you can imagine how different it is. And there's so much clutter around. It can be any time in the night or day. And you don't have much help. And this patient is not only someone who needs airway support, they also need hemodynamic support. The operative factors are also important. It's not always the anesthesiologist whose core competency is airway management. You can have people from different specialties with varied levels of skill. And the most important is the patient factors. These are not the fasted, optimized patients who come for surgery. And they often have an imbalance between the oxygen consumption and delivery. So they're already starting at a disadvantage, and they have a short apnea time. I'm sure you have seen the Benioff curves. And you look at patients, and on the x-axis, you have the time to desaturation, and on the y-axis, you have the saturation. And these critically ill patients, they start with a low FRC, they have a high oxygen consumption, and they rapidly desaturate during apnea. So these are not like the patients, the stable patients who come in the operating room. And of course, we gave recommendations for team preparation and various human factor considerations that are really important. In the interest of time, I won't go through all of this, but I'll talk a bit about airway assessment. Now, airway assessment, as you know, in the critically ill patient is difficult. You have less time. The patient may not be cooperative. They may be comatose. They may be, rowdy. You may not be able to assess the airway. The Makocha scoring system from Audrey de Jong in France is a validated scoring system that can be used in critically ill patients. And what I like really about this is it not only looks at anatomical factors, but it also looks at physiological factors. So if you see, there's 1 point for coma and hypoxia, and it also looks at the experience of the operator. So if you're a non-anesthesiologist, you get 1 extra point. The total score is about 12, and of course, the higher the score, the higher is the risk of intubation. We also gave recommendations for various parts about performing the procedure, and I'll just give you a little overview about this because there isn't much time. Of course, the default should be a rapid sequence intubation and a modified one where you use a sedative hypnotic drug, rapidly acting muscle relaxant. Gentle mask ventilation should be considered in these patients to prevent physiologically difficult airway. A little about positioning. Now, these patients come to you in acute hypoxic respiratory failure. They're never lying flat. They're sitting up, they're bending forward. And what are we trying to do? We're trying to make them flat to try to intubate them. This is not the position in which they are comfortable. In addition to this, it's nice to give them a 20-degree head-up position because these patients often don't have normal lungs. And in the flat position, the posterior portions of the lung actually become more prone to atelectasis. So it's good to keep them in a little propped up position, 20 degrees, while pre-oxygenating and also during tracheal intubation. You may have all seen this paper in NEJM, which talks about the pre-oxygenation. Now, the pre-oxygenation is really important prior to tracheal intubation. As I mentioned, these patients have a short apnea time. They rapidly desaturate after you give them muscle relaxant during RSI. And this is a study that comes from the Vanderbilt group that compared non-invasive ventilation for pre-oxygenation during emergency intubation, almost 1,300 patients, and they showed that among critically ill patients undergoing tracheal intubation, your pre-oxygenation with non-invasive ventilation decrease the incidence of hypoxia. Now, you have other techniques like high-flow nasal oxygen. What about the use of high-flow nasal oxygen for pre-oxygenation and continued during attempts at intubation compared with non-invasive ventilation? Now, this Florali-2 trial is the first trial that's big, well-powered, randomized controlled trial that's compared these two. And interestingly, they found no difference. Their primary endpoint was saturation falling to less than 80% during tracheal intubation. There was no difference whether you use high-flow nasal oxygen or NIV for pre-oxygenation prior to tracheal intubation. However, interestingly, in the subgroup of patients who had a PaO2, FiO2 less than 150, the non-invasive ventilation was more superior. And this is probably because of more definitive delivery of PEEP in this patient. And you must have also seen this NEJM paper. This is a little controversial about giving bag mask ventilation, gentle mask ventilation during rapid sequence intubation. Now, during an RSI, we usually don't ventilate patients, right? Because there's always that worry about the perceived risk of aspiration. But these patients who are critically ill with ARDS and a pneumonia also have a risk of desaturation. So there is a balance that you have to maintain. And this group actually, in one group, they gave gentle mask ventilation during RSI, and the other group, they didn't give any mask ventilation. Of course, the saturation was higher in those patients who didn't receive who received the mask ventilation. This study was criticized because it was not powered for aspiration. If you need to do a study for aspiration, you'll need thousands of patients. Nevertheless, there was no increased risk of aspiration in patients who got gentle mask ventilation. So this study does give us some confidence that in those patients who are at a high risk of desaturation, you can consider giving gentle mask ventilation. And then a bit about delayed sequence intubation. We talk about rapid sequence intubation. What is delayed sequence intubation? Now, this is a first randomized controlled trial that comes from one of my colleagues in India. And delayed sequence intubation is when you give, sedative doses of ketamine to these rowdy hypoxic patients. These are the patients who need oxygenation the most. And what we do is we just induce them and try to intubate them and don't pre-oxygenate well enough. So you can give like sleep doses of ketamine, about 1 milligram per kg to these patients, get them calm and pre-oxygenate them well. And the good thing about ketamine is it doesn't produce any respiratory depression. Pre-oxygenate them well and then intubate them. And this was an RCT in which they gave delayed sequence intubation to one group and the other one they just performed the conventional rapid sequence intubation. And you can see the oxygenation at all time points was significantly higher in those patients who received DSI. So in summary, you pre-oxygenate with NIV compared to high flow if you have patients who are at a high risk for desaturation. Continue your apneic oxygenation during your nasal oxygenation during attempts at intubation. Gentle mask ventilation, especially in those high-risk patients who are not at a very high risk of aspiration, of course. And in patients with a physiologically difficult airway who are difficult to mask ventilate, you can consider this delayed sequence intubation technique. Now I'll come to the next part, which is cardiovascular collapse. Now, as you saw in the INTUBE study, 42%. Now, why do patients have hypotension after tracheal intubation? I've often wondered about this. So it's often their critical illness itself, sepsis. They may be on vasopressors. The drugs that we use for critical tracheal intubation, this is really important. Propofol, benzodiazepine, like the patient I showed you in the beginning. The loss of sympathetic drive. Now, this is really important. These patients who come with acute hypoxemic respiratory failure, they're tachycardic, they're very restless. They have hypertension, they have high heart rate. And this is because of the sympathetic drive. But the moment you anesthetize them and they lose their sympathetic drive, you have precipitous fall in blood pressure. So it actually kind of fools you and you think the patient is hemodynamically stable. And you have to be very cognizant about this. The positive pressure ventilation is also very important because when these patients are already hypovolemic and you intubate them and you give positive pressure ventilation, especially with high tidal volume, you decrease the venous return, you decrease the cardiac output, and you have fall in blood pressure. So if you look at the drugs used for rapid sequence intubation, we recommended that you use relatively cardiostable drugs like ketamine or etomidate, and either suxamethonium or rocuronium, unless contraindicated, of course, for suxamethonium, could be used for rapid sequence intubation. And this is a meta-analysis, a Bayesian meta-analysis done by Yuki Kotani and his group, which compared ketamine versus etomidate. So which of the drugs should we use? I know ketamine availability is a bit of a problem. And this Bayesian meta-analysis actually found more probability that induction with ketamine compared to etomidate for tracheal intubation was associated with improved survival. But the real message is you could use either, but avoiding using drugs like propofol. And I'll also go back to the Intube study. We did a subgroup analysis of all those patients who had hypotension, and we looked at factors that were associated with increased risk of complications. And we published this in the Blue Journal, and what was really interesting is that those patients who developed hypotension, the use of propofol, was identified as a modifiable intervention significantly associated with cardiovascular instability. We love to use propofol in the intensive care unit, but using propofol in critically ill patients, and this was irrespective of the starting blood pressure. So we have to be very careful about using this drug in critically ill patients. Now, as I mentioned, the hypotension is 42%. We have to do something to prevent it rather than treat it. And this is the first, usually we give a fluid bolus because we know patients get hypotensive, but no one's actually tested it in a randomized controlled trial. And this was the first randomized controlled trial from Vanderbilt that looked at giving a fluid bolus. They gave 500 ml of normal saline, and in the other group, they didn't give any fluids, and their outcome was looking at cardiovascular collapse. And interestingly, there was no difference in the primary endpoint, whether you gave fluid or not. However, in the subgroup of patients in whom they received positive pressure ventilation, either NIV or they got gentle mass ventilation, there was a benefit of fluid. So this group went ahead and did the next study called the PREPARE-2 study, and here they took only those patients who got positive pressure ventilation and give them gem saline or no saline. And interestingly, there was no difference. So the fluid bolus that we're giving prior to intubation is not making much of a difference. Of course, there were limitations in both of the trials, which I won't talk about in the interest of time. And the hypotension is real. So we have to do something to prevent rather than just treat this hypotension. And there are 2 trials underway. This is the FLUID trial that has just been completed in my center. And we're using a low dose of vasopressor. So I'm still not convinced that fluids don't work. So in one arm, we have fluid, and in the other arm, we have a low dose of vasopressor. We're using norepinephrine, 0.08 microgram per kg per minute, given as a slow infusion, 10 minutes prior to intubation, because we give it through a peripheral line. Not all patients have a central line, and we're looking at the incidence of cardiovascular collapse. And the other study, I'm also part of this is from the ESICM, the prevention trial. This is ongoing, where they're using low-dose norepinephrine versus usual care. So the results of this will actually tell us, whether this actually makes a difference. From the perspective of hemodynamic monitoring, we need to monitor the hemodynamics. You may use fluids or vasopressors. The results of this trial will give us the answer. And periprocedural ultrasound can also help you assess the hemodynamics before you have lines in. We all know that video laryngoscopy should be used. We analyze the data from the Intube study, and it was actually though it was an observational study, it was the first study that actually showed us that VL increases first pass success in critically ill patients, because until now the data was controversial. If you're using other tools and you have this big randomized controlled trial, of course, showing you that VL is superior to DL. So even in critically ill patients now, we should consider VL during the first attempt at intubation. Stillet and bougie, I'll just quickly tell you, we usually use a stillet or a bougie as a rescue. This is the randomized controlled trial from Samir Jaber that's actually showed that using a stillet during the first attempt at intubation increases first-pass intubation success. And this was a study from Anne Vanderbilt that compared stillet versus bougie. Again, showed no difference, but taken together, these studies actually show that you should use stillet and bougie not as a rescue, but during the first attempt at intubation in critically ill patients. The last part I'm talking about is esophageal intubation. Unfortunately, this should be a never event, but unfortunately, we still have a lot of esophageal intubations happening and missed esophageal intubations, and you can see the complication rate is significantly higher in critically ill patients if you use video laryngoscopy. And we should use capnography. We have recent two deaths in UK and in Australia because of a missed esophageal intubation, and this prompted us to make this guideline from the Puma group for esophageal intubation. And the most important thing in this guideline was to use a video laryngoscopy and waveform capnography. And I'll share this graphic from this paper. You should look at consistent waveform capnography, during tracheal intubation, following tracheal intubation. Not done very often in the intensive care unit. From the Intube study, we found VL was used in only 17%. And this was not in the developing world, also in the developed world. And look at people are still auscultating. Very few are using waveform capnography. Only 1 in 4 people are using waveform capnography, clinicians. And we have a long way to go. So in conclusion, I'd like to say that complications associated with tracheal intubation, they remain high. And hypotension and hypoxia are the most common. So remember, hypotension is even more common than the hypoxia. The Intube study has shown that this increases the risk of 28-day mortality in these patients. So don't take it lightly. Don't take it as something you can easily correct. This has an impact on mortality. And these strategies that I outlined can help you in safer management of the patient. And most importantly, tracheal intubation is a life-saving procedure. But this life-saving procedure can actually lead to a life-threatening situation if it's not managed properly. I'll leave you with the graphic from our paper, and I thank you very much for your time.
Thank you, Dr. Sheila, for this comprehensive review. I really enjoyed it. We have time for 2 questions and 1 question. We have to do it because the topics are not the same. I have 1 question to you. Do you have like a rapid airway team in your ICU where you have like ENT or respiration therapist in case the intubation fails, by all means, to come and do any surgical maneuver to save the life?
Right. So, this would be ideal to have a team of experts who'd come and do every intubation also for rescue. Well, practically, I know in UK during COVID they had these kind of teams, but practically it's very difficult to implement because you may not have these people available at all time. So I think really the way forward is to enhance the intubation skills, make people in ICU aware of the risk of complications because, the eye does not see what the mind doesn't know. So it's really important that they should be aware that these patients will have complication, hypotension in 1 and 2. So these kind of things, and to increase the use of video laryngoscopy and tools like Stellate and bougie upfront during the first attempt at intubation itself.
Thank you. 1 question only.
No time for giving fluid.
No time to prepare them on and give fluid, that's one. Second, have you ever tried what we call side bed intubation, in which you just, unless he's overweight, you just drag the patient and you go to the left side of the bed and intubate what we call nowadays head-up intubation. It's easy. The last thing for the question of difficulty, put some quick tracks. The quick tracks for emergency tracheotomy, it's easier than having other people to assist you. In an emergency situation when there is no time even to do what we call tracheotomy.
Yeah. So thank you very much for your question. So first of all, I don't agree that there's no time for giving fluids because it's not that patient comes and you have just 30 seconds for intubation always. So even when this patient's on NIV and you know you're going to intubate this patient shortly, you could give fluid during that time. Of course, we don't know whether fluids, really, the results of the trial will actually tell us whether fluids are actually helping or not. Yes, by the said bedside intubation in people who are skilled with video laryngoscopy today is feasible. I don't endorse any companies, but of course, it shouldn't be tracheostomy. It should be cricothyrotomy using whatever technique you're familiar with, whether it is scalpel bougie technique. This is universally available. All you need is a scalpel, a 6-number tube, and a bougie, so you can do it in any resource setting. Or you can use the ready commercial sets that are available, like you mentioned, to do a cricothyrotomy. But remember, in an emergency, when you need to do neck rescue, and you failed all your upper airway techniques, it should be a cricothyrotomy and not a tracheostomy in an emergency.
Thank you.
Thank you very much. It gives me great pleasure to present the next speaker. It's Dr. Thaminu. He's an associate professor of surgery, the director of the Trauma and Acute Care Surgery Fellowship, head of the Trauma and Acute Care Surgery Unit at the Department of Surgery, College of Medicine, King Saud University at KSA. And he'll be talking about blood preservation strategies in trauma.
Thank you very much. Good morning, everybody. Thank you very much. I'm also very thankful that I see all these people up here this morning. I'm going to try to be quick to respect the time. So I don't know if my slides are here. Okay, no conflicts of interest to disclose. I think it's very important to identify that the goal is to save life and not to just to prevent giving blood. It is a means to an end. So I see a lot of people concentrate about not giving the blood or not giving the blood products as opposed to concentrating on saving life. And so if you feel that the answer is blood or blood products, please go ahead and give it. But obviously, this needs to be done with reducing complications of blood and blood products. There are multiple strategies that are involved in reducing the amount of blood or preserving blood given. The most important thing is stopping the bleeding. You need to, first of all, dedicate a lot of effort to stop the bleeding. And then after that, after the bleeding has stopped, there are conserving techniques to try to minimize the amount of blood that is being transfused, the most important of which is restricting blood transfusion or lowering the triggers. We've always been trained to try to transfuse patients up to a level of, or to keep the patient around the level of 9 or 10. But more and more evidence, starting from the TRIC trial a long time ago, and all the trials that followed that, have shown that reducing the hemoglobin or targeting a trigger level of 7 to 9 is safe in trauma patients. Ultimately, within the ICU, also trying to minimize blood loss that is associated with blood extraction, with tubings, is a very important strategy to try to minimize blood. And then ultimately, in the operating room, if you are a surgeon, in the operating room, trying to use technology to save blood. If you expect that there's going to be a lot of blood loss during the surgical intervention, using cell savers to try to auto-transfuse back some of that blood to the patient is a very good strategy, although it is not available to a lot of people, and it requires specific technology and training within the center. Obviously, damage control resuscitation is another standard of care strategy now that has been in use for a very long time. And basically, in this strategy, you limit resuscitation in the first phase during the time of controlling the bleeding, where you target a lower level blood pressure of about less than 90 systolic. And this prevents the infamous permissive hypotension methodology, and this prevents you from popping the clot. But ultimately, but while you're doing that, you're trying to control the bleeding very quickly, and then after you achieve source control of bleeding, then you do very rapid intravascular volume restoration using blood and blood products. the balanced ratio approach to blood resuscitation has also been a standard of care for a while, where from the military experience in Iraq, we've shown that closer to 1 transfusion carries improved mortality rate compared to the regular component therapy. And this has been introduced into massive transfusion protocols, where this has become the standard. And with the introduction of, it's been noticed in literature that although this knowledge is there, the utilization of balanced transfusion is not very effective on actual transfusion at the bedside. And introducing this into massive transfusion protocols has really helped, where the blood bank becomes, instead of it being a warehouse, it becomes your partner in trying to develop, in trying to resuscitate the patient. And it sends you predetermined amounts of blood, platelets, plasma, to try to be able to resuscitate the patient in a one-to-one manner. And this has been replicated in trauma patient, in medical care, and in other surgical pathology. And again, we've shown that using these approaches has led to improved outcomes and decreased waste. Transfusion adjuncts are very important also in trying to, because if you're not really giving the transfusion adjuncts and appropriately, you end up giving blood but developing dilutional coagulopathy, and then having continued bleeding, having to give more blood. So it's very important to know about your transfusion adjuncts. Tranexamic acid has been the new kid on the block. Well, not new anymore, but ultimately you give tranexamic acid to try to inhibit the fibrinolytic activity within the blood. And this is being shown to be effective if you give it within 3 hours of injury. You give 1 gram push over 10 minutes within 3 hours of the injury, followed by 1 gram over 8 hours. And this has also been demonstrated to be beneficial if you give it in the pre-hospital settings. So either you give the traditional 1 gram and over 10 minutes, followed by 1 gram over 8 hours, or you could also give just 2 gram bolus. It's also been shown to be safe. Ultimately, calcium is also an important adjunct, where you need to consider whether the patient is developing hypocalcemia or not. And we're trying to move from the lethal triad to the lethal diamond, where hypocalcemia is added to acidosis, coagulopathy, and hypothermia. Ultimately, keeping the blood warm is very important. We've moved from the rapid admixture technique that we used to warm blood to the level 1 infuser, and all the trauma surgeons and emergency physicians in the trauma bay are probably used to this, or to where you warm blood through the water bath, or to actual just physical warming through the tubes. Ultimately, it is very important to maintain the blood warm as it's going into the patient. The newer introduction of whole blood is very interesting, where although we try to achieve one-to-one transfusion, you're still introducing diluted blood, where the hematocrit is around 29, the platelets are around 90,000, and the clotting factors are approximately half of what is in normal blood. And so we've seen, again, from the military experience, that whole blood is very beneficial, where it's associated with less mortality. And now the introduction of whole blood into the civilian practice has been shown to be very effective. It's been associated with a 4-fold increase in survival, with 60% reduction of overall transfusions. And this is regardless of the location of the transfusion, the injury severity, or the presence of head injury. So in total, whole blood is looking as more and more beneficial, especially in trauma patients. And we've have more literature that shows that when you give Because the previous paper has basically looked at giving whole blood, regardless of how much whole blood versus component therapy was given. But when you look at patients who receive more whole blood rather than component therapy, this has also been shown to be associated with lower 4-hour and 24-hour mortality and decreased 24-hour transfusion requirements. The challenge is actually, who of us here has access to whole blood? Can you show by raise of hand who has access to whole blood? So I find it, well, Canada, I guess. But I find it very challenging in our part of the world is that up till now, I think the regulatory considerations in our countries have not yet approved whole blood. And so even, after you get away from the hurdle of regulations, there are actually other considerations that you need to take into account. Whether you use, when you're giving whole blood, whether you give O negative or O positive whole blood, whether you give it to male versus female, whether you get whole blood from males compared to females. So there's a lot of clinical and non-clinical considerations beyond the actual regulatory hurdles that will prevent or are still preventing utilization of whole blood in our part of the world. So the last thing that I wanted to touch about is goal-directed therapy. We've been really advocating for goal-directed therapy everywhere in our practice in the intensive care unit. Blood transfusion and blood component transfusion has been an area where we've had the technology to be actually utilize goal-directed therapy for transfusion. But again, due to, and this is basically the gram where it shows, depending on the result of the gram, you might be, it tells you or it gives you a hint whether you need plasma, you need cryoprecipitate, you need platelets, or you need antifibrinolytic therapy. Just for the sake of the time, so having access to this goal-directed therapy or vasoelastograms really helps you to improve hemostatic management, quicker decision-making where you're getting the result within 15 minutes as opposed to the 30 or 1 hour, 30 minutes or 60 minutes that you get with your regular lab results. And it reduces the waste because you give what the patient is actually needing. And it helps you detect trauma-induced coagulopathy. The challenges here is actually the technology availability within our hospitals. So you need to really convince the administration about the benefit of having it. The cost is a challenge, the equipment availability, and then the training to actually read the results and make decisions based on that because it's at the bedside. You really need the people at the bedside to be trained about how to read it and how to react on it. And then sometimes people have noticed that it ends up leading to overtreatment, where the patient you would not normally have given any intervention, but because you have access to tegel-rotem, you end up overtreating with and transfusing when you might not have. But this might be a benefit because you're basically identifying compensated or non-overt coagulopathy. So in conclusion, blood-preserving strategies in trauma really hinges about minimizing the losses, balanced resuscitation, and hemostatic control. Thank you very much.
Thank you.
Seria, huh?
Great keeping the time. We were asked to keep the questions till the end.
Sure.
It's a privilege now to introduce Dr. Nawaf Al-Shahwan. He's a North American trained general trauma surgeon and intensivist. He's American and Canadian board certified in general surgery and critical care medicine. He completed his residency training and fellowship in surgery and critical care in McGill University in Montreal, Canada. He is currently the Director of Trauma and Acute Care Surgery at King Saud University Medical City and the General Surgery Residency Program Director in KSA. And this morning, he will discuss about a very important thing in trauma, vascular injuries. Should Riboa be used for prime time? Dr. Shahwan.
Thank you. Good morning. Who here is a surgeon? Well, other than my friends and Trasma. Okay. Who knows what a Riboa is? Non-surgeons. Who has ever seen or used a Riboa? Like I see, like, again, Dr. Asma, non-surgeons. All right. So we're going to keep it short. Are we ready for prime time? No. Thank you. So I'll talk a bit about what is a Riboa, where did it start, and what's the idea behind a Riboa. So preventable death and trauma is mainly from torso hemorrhage that you can actually get access to, whether in the OR or in the interventional radiology suite. In extremity trauma, it's easy because we have tourniquets that you can apply, and usually they work well. If you get them early in time and you know how to use them, it stops bleeding. But in the torso or in the non-compressible hemorrhage, tourniquets don't work. You can't apply a tourniquet over someone's neck or over someone's abdomen. That usually is not going to work. So sometimes, to give you time to actually get the patient to the intervention that they need, you can occlude the aorta. To occlude the aorta, there's two ways of doing it. You can either open the chest and put a clamp on the aorta, and as you can imagine, that could be quite morbid. Or you could insert a balloon through a catheter inside the groin and inflate the balloon to occlude the aorta, to buy you time until you get the patient to the intervention that they need. The first description of this technique was actually more than 80 years ago now, or 70 years ago. The surgeon, Carl Hughes, published his 3-patient case series, where the first patient, I don't know why he included it in the series because he never got a Riboa, but it was still there. I think he mentioned that he thought he couldn't insert it in time. The other 2 patients actually got to the OR, but then died afterwards. And then nothing for 30 years, until the late 80s. Case series, 23 patients, less than 25% of them actually survived. And then nothing for another 15 years, until we get some animal models. And I'm talking about nothing, like no publications, no thought, no discussion about this technique at all. The animal models in the early 2000s shows that this actually might work. And then, again, same theme, nothing, for about 10, 15 years, until the early 2010s, where we start getting some publications and some case series that describe using this technique. This is a case series of 6 patients where they all had the Riboa and they all survived to the OR. Another case series where they compared patients who had Riboas versus a wrist thoracotomy, and as you can see here, the patients who had Riboas actually survived, had a higher chance of surviving. So positive news, and this starts getting some track. Other potential use of this technique, as you can imagine, you can put a balloon in the aorta to stop bleeding in a woman who has bleeding after delivering, and a patient who has a ruptured AAA, a patient with the GI bleeding, for example. I thought I'll be the guy. I thought I'll be the guy in my hospital who gets called for any bleeding patient to insert a Riboa, and I was wrong. I'm going to show you now in time what happens. So the technique, you get arterial access into the common femoral artery. The common femoral artery, not the superficial femoral, not the common iliac. So it's a very specific area in the body that you should actually access to insert this catheter. The catheters that were initially published or used are the 9 French catheters. As you can imagine, it's a huge catheter, it's large, to insert into a vessel. This is why we have to target the common femoral. If you insert a 9 French sheath or catheter inside the superficial femoral, which is a bit lower, then you risk occluding that vessel completely and you develop limb ischemia. And as you can imagine, that's not something good for a patient who's actually just had a major trauma. And then came the ER Riboa. The ER Reboa is a smaller catheter. It's a 7 French catheter. So the thought is, even if you insert it into the superficial femoral, it's going to probably be okay. And as you can see here, there is an arc line lumen at the tip. So the moment you inflate the balloon, you see in real time the patient's blood pressure improve. And then you know that you have now proper hemorrhage control. You can actually have some time to take this patient to the operating room or to the IR suite. And also, the ER Reboa does not require a guide wire to introduce. You can it comes in loaded with the peel-away sheath that you can use on the spot. So, as you can imagine, the patient's head on the right side. This is the groin. We're accessing the Reboa from the left groin. This is the inguinal ligament, just underneath. So there's this specific area where you try to target in the common femoral artery, there. So if you put it here, it's too low. If you put it there, it's too high. So you have to get into this area. So this requires specific skill set that not everyone has, right? And usually the person who has the skill set is not at the bedside when the patient comes in. So the goal of Reboa, I apologize for the next picture, it's going to look horrible, is to try to end up with this, and including an aorta, instead of this, and opening the chest to actually apply a clamp on the aorta. So there are 3 zones for aortas. Zone 1, that's above the diaphragm. Zone 3, below the lower sternal artery. And then the zone 2, which is in the middle, in between. And that's the zone you don't want to have a balloon up there inflated, because the patients would develop visceral ischemia secondary to that. So usually Reboas, when we talk about them, we talk about either zone 1 inflation, and that's for any abdominal bleeding, for example, or pelvic bleeding, but zone 3 specifically for pelvic or lower extremity bleeding. And that's the most commonly used inflation area nowadays. You have to confirm positioning with an X-ray, and we're going to talk about why is that important. So you need someone to actually know how to insert it. You need an ultrasound. And you need probably 2 to 3 physicians to be able to insert it. One of them has to keep an eye on the patient overall, and a proceduralist and an assistant. So we stopped in the early 2010s, and we start seeing an influx of data saying that this is the best thing ever. We're not going to need any trauma surgeons anymore. Again, going into up to the late 2010s. Problem with all of this data is there's a lot of selection bias, a lot of survival bias, a lot of it is case series, and there's always a wrong control group in almost all of these papers. This is a T-QUIP analysis where they matched, using propensity score matching, Reboa and non-Reboa patients, 2-to-1 matching. Turns out that transfusion requirements are the same, but mortality was worse with Reboa, AKIs, lower limb amputations, and angioembolizations. More time to angioembolization and laparotomy. So Reboas actually get you to spend more time in the trauma bay trying to insert a catheter, while you actually should be actively trying to resuscitate and take this patient to the OR or take them to IR. The American College of Surgeons and the American College of Emergency Physicians sat together in 2018 and came up with a consensus. And then again in 2019 came up with a consensus again. And guess what? There is no high-grade evidence showing that actually Reboa works. Limited use, limited setting, and limited time to occlude the aorta. So not that helpful. This is something that was described initially in the military, the junctional tourniquet, and it has been compared to Reboas. It seems a bit better in terms of having some distal flow versus an occluded aorta completely. But it never really gained a lot of interest as much as the Reboas did, mainly because it doesn't really work well for intra-abdominal bleeds. It works well for junctional bleeds, such as the groin and the axilla, hence the name junctional. The East Practice Management Guidelines looked at this in 2021, trying to address if actually Reboa is still great thing as much as we thought it is. And they said, based on low quality evidence, we cannot recommend for or against Reboa. I believe this is the aorta registry, a review from the aorta registry that looked at, with time, how are these patients actually performing with more experience that we're gaining from using these techniques. Turns out that there's more increased Reboa use, from about 40% to about 47%. But then there's more distal emboli, more AKIs, more pneumonias, more time that delays actual proper hemodynamic stability or normality, and more time to definitive hemorrhage control. So, it's not good. This is a review from 6 quite busy level 1 trauma centers in the US, where they found out they only used it for 75 out of 8,000 patients in 1 year. So 0.92% of those patients only received Reboa. Again, it's starting to show that it's, with time, less and less people are using it. Now we're talking the early 2020s. And then we look deep into the data, you find that about 80% of these patients were from 3 centers. So the other 3 level 1, very busy trauma centers only had 5 patients per year where they inserted the Reboa, so quite low. The patients who had Reboa, who survived, ended up requiring a laparotomy. Again, the majority of these patients had it at level 3, zone 3. Zone 3 are patients who had pelvic injuries. So you're trying to avoid an OR and trying to get them to IR to embolize them. But despite that, 3/4 ended up needing an OR. And then 25% of them required repositioning. Remember we showed you the X-ray showing the positioning of the, so if it's too low or too high, you have to reposition it. So unfortunately, this time of repositioning was not counted towards the actual time that it took from decision to Reboa to balloon up, because that's the metric that majority of the studies use to justify the use of Reboa. So with time, 9 French catheters become 7 French catheters, multiple training courses, and until now, more and more publications, as we can see, with time. Questionable utility, complications are high, and weekly updates. And it's so fast, like the rapid pace of getting papers just published, to the point that they're sometimes making silly mistakes in their publications. As you can see here, IV fluids, 4 liters versus 2 units. And it's, until now, this is still showing as 2 units on the official trauma acute care surgery website, despite me emailing them about it 10 days ago when I was preparing for this. It's hilarious. So, who gets a Reboa? I think the majority of, I can speak of my 2 colleagues here who are trauma surgeons, and I can assure you that if they're going to use a Reboa, it's going to be this guy. So a guy who comes in with a blunt trauma, who has a negative FAST, a pelvic fracture, and the Reboa goes in zone 3. And this patient has to be someone who's non-responder or unstable. Sorry, non-responder or transit responder. So patients who respond to resuscitation and get improved hemodynamics afterwards, non-transiently, they would not need a Reboa. So going back to the question of is it ready for use in vascular injuries per se, this is something I worked on as a fellow. We looked at actual complications caused by Reboa. And the vascular complications caused by Reboa are 8%. And here we excluded case series and below, I think, 3 or 4 patients. And we also excluded case reports. So we looked at published literature, and this 8% is high. 8% requiring either vascular intervention, distal amputation. So they're quite morbid. They're not just a small hematoma in the groin. They're serious access complications. But also because it was a systemic review, when we looked with time, the smaller 7 French sheaths had decreased incidence. So that was a bit promising, that maybe the smaller sheaths, the ER Reboa, is going to have better outcomes in the future. Interestingly, in the 2025 European Society for Vascular Surgery and their practice guidelines, they recommend against Reboa as much as they recommend against using clinical exam to exclude blunt cerebrovascular injuries, and as much as they recommend against using X-ray alone to rule out a blunt aortic injury. So it's really falling out of favor these days. Yesterday, this was published, looking at patients who have vascular injuries inside the abdomen. It was a TQIP review. Non-surprisingly, Reboa worse outcomes across the board. Thank you very much. I do not recommend using Reboas in vascular injuries.
Thank you for this very interesting, comprehensive talk. We'll leave the questions for 20 minutes from now.
Again, thank you very much. It gives me great pleasure to introduce Dr. Ahmed Al-Braikan. He's an assistant professor and consultant of trauma and acute care surgery and critical care at King Saud University, Al Habib Medical Group, and he'll be enlightening us on the difficult airway in the ICU.
Assalamu alaikum wa rahmatullah. Thank you for inviting me to this wonderful conference. It's always a pleasure to be in the lovely state of Kuwait. My friend, Dr. Muhammad, thank you for the presentation. I'm going to be talking a bit about difficult airway in trauma. This might be more of a surgical talk rather than an intensive care talk. But you know what? Most of our trauma patients end up in your ICU, so just bear with us a little bit, huh? So to introduce, airway management is essential in trauma patients. I'm sure you all guys have the ATLS, and you know that airway is considered the A in the ABC approach. The airway is an essential component of managing trauma patients. But the airway is challenging. I'm sure Dr. Sheila elaborated on the physiological challenges of the airway, but in trauma, usually you have physiological, anatomical, and also some environmental challenges to secure the airway in a trauma patient. Sometimes you're in the ER. Nowadays, we're talking about pre-hospital airway securing, so the environment also plays a major role in your airway management in trauma patients. Of course, I will start with the concept of C before A, but before that, we'll show you some of the trauma airways that we have dealt with. I was personally involved in the two airways to the left. A bit challenging, huh? I apologize for the pictures, but at least the two on the left, they survived. So there is a paradigm shift. I have to elaborate on this in the trauma societies now of emphasizing circulation before airway, and I don't know if I agree with this, but you know, the philosophy behind this is that what you heard about just now. You know, sometimes the physiology of the patient is what's making him sick, and the airway is not really the life-threatening matter that you have to deal with. Taken a case, for example, of a penetrating wound to the abdomen, and you want to apply ATLS. The patient is in severe hemorrhagic shock. Now, if you jump and secure the airway before you fix the hemorrhage, then you end up with a very bad physiology of a patient, and then the patient, you create another problem for yourself. However, for patients such as those, you cannot fix the circulation before the airway. If the airway is really, really compromised, then it's A before C, always. However, just remember sometimes the A does not need your immediate management yet. So this is the first message I want to send, because you're going to hear this a lot now, C before A, C before A. But at the end of the day, how you assess the airway, because sometimes simple maneuvers can open the airway, and that's all you need. The airway is not really compromised to the point that you need to intubate and turn this into a positive pressure ventilation and you know, deranged physiology of the patient. You just need to open the airway and then take care of the more pressing stuff of hemorrhage control and pelvic fractures and all these things. So, as I said, if the airway is really obstructed, then it's the number one problem that you have to face. And if it's obstructed, it leads to about 35% of pre-hospital deaths. Also, if you delay or if you fail in intubating trauma patients, this will lead to poor outcome. That's why you have to recognize that the airway is really your main concern now. And you have to remember that in trauma, airway can be really difficult. Okay, so why do we have difficult airways in trauma? Again, because of direct airway trauma, which is not that uncommon nowadays. You have maxillofacial injuries, facial injuries. You need to immobilize the cervical spine as part of your ATLS, so you're creating a difficult situation for yourself to manage the airway. Again, environmental factors. Sometimes you have poor access, poor light. This is the trauma bay, is not as controlled as the operating room or even the ICU somehow. The patient may present already hypoxic, already aspirating. There's bleeding in the mouth. And you have also multiple injuries. You have to worry about what's happening in the abdomen, what's happening in the pelvis, not just the airway. So, one way of assessing how difficult your airway is going to be is to use mnemonics, lemon and bones. So lemon is going to be, you look externally, you evaluate the 3-3-2 rule, you do the Mallampati score, you assess for obstruction, and you check for neck mobility. Now, that being said, most of the time, the Mallampati score is not very accessible for you in trauma. The patient might not be awake, he might be combative. The neck mobility, you know that you're going to have a neck mobility issue because this is a trauma patient and he has cervical collar. Again, for bones, if the patient has a beard, you have to check also the teeth. If they are obese, if they are elderly, which is less of a trauma, but now we're seeing trauma also in the elderly population. And if the patient is already snoring, very bad head injury, not awake, and you hear snoring, this is usually a bad sign. For every scenario that you've seen, maybe as a critical care doctor, where you might anticipate difficult airway, there is also a similar scenario for trauma patients. If you have limited mouth opening, then again, in trauma, you might have you always have the C color, and sometimes you have also oromaxillofacial injury. You more often cannot position the patient the way you require. You've seen in Dr. Mitra's presentation how the positioning is very elaborate. You will not be able to do that in trauma patients. They are immobilized because of C-spine injury. There's often a lot of secretions with blood and vomiting, especially if there is an airway injury or if there's a maxillofacial injury, and you have to really worry about that. Sometimes the problem is actually penetrating neck injury, and then your whole problem lies within the airway and major vessels of the neck. Sometimes it's also difficult to do bag mask ventilation, again, because of the nature of trauma patients. And again, when you need to pre-oxygenate your patient or secure some form of at least, a temporary airway, that might be a problem, again, because of direct injury to the face or presence of contamination. So, for specific situations in trauma, and I know in the Gulf countries, in Saudi and here in Kuwait for sure, we have significant patients with traumatic brain injury because of road traffic collisions. And there are also specific considerations to think about when dealing with airway and traumatic brain injury patients. You have to understand that, hypotension and hypoxemia independently risk factors for worse outcomes with TBI patients. You have to do your best to prevent secondary brain injuries by preventing hypoxemia and hypotension, and these are all common occurrences in your trauma patients, especially when you're trying to secure the airway. But the good thing is that if the patient is not really ventilating that well after traumatic brain injury, if there is a presence of apnea, it does not really necessarily mean bad outcome. So you don't have to rush to really mechanically ventilate the patient and secure the airway immediately because of apnea. Sometimes you have time to deal with other injuries. Just open the airway, gentle bag mask, because apnea in itself is not a marker of bad outcomes. You should only proceed to really secure airway, which is an endotracheal intubation, after you make sure that the patient is properly resuscitated, to avoid any physiologic disturbance, because this will lead to secondary brain injury. If there is post-intubation, again, most of the time we bag mask because we are adrenaline rushed and we want to ventilate the patient, but really avoid hypocapnia because it also negatively affects patient outcomes. Okay, so what about patients with suspected cervical injuries, which is really, most of our patients when they present. My only message here is usually we remove the C-collar and we do manual inline stabilization, but it doesn't have to limit your jaw mobility. You can see on the left where the inline stabilization is residing over the jaw and it's preventing jaw mobilization. That's not necessary. You can position your hands slightly up. You can still protect the C-spine while the jaw is mobile. This is very important. In the contaminated airway, this is really common. You have blood, you have vomit, sometimes you have loose teeth. So one technique, we call it the salad approach, is that you really put the suction to the left of the direct laryngoscope. You use the direct laryngoscope to secure one suction to the upper left part of the mouth. We call it the salad approach. And then you can have another suction to clear your view, and then you insert your ETT tube. This is very important. There is facial fractures. Usually there is blood dripping from the mouth back into the airway. And when you fix your suction in that area, it really helps open up the view for you. For maxillofacial injuries like this patient is actually a blunt injury. We had this patient and something flew out of the airbag and the car, and it was a very round metal object that it hit him right in zone 3 of the neck, and it was lodged just behind the ear. It was causing active bleeding from a neck hematoma, facial artery injury, and here we did not need to intubate the patient in the ER because he was awake, he was stable, he was actively bleeding. We knew we had to do something because it was, again, a build-up, but this is a classic scenario where we called for help. The patient was stable, we had time. If the patient was not protecting his airway, then you don't have time. You have to really act. Either you proceed with the rapid sequence. If it doesn't work, you go for the next step. But if the patient is stable and cooperative, you can go to the operating room, a more controlled situation, and then there you can either do awake intubation through an endoscope, an intubating endoscope, or a direct laryngoscopy, or you can do a front of airway, front of neck access airway, which we'll talk about it later. You just have to, the point of this is to have a plan in your mind, a series of questions to ask yourself, and to have a plan on what to do based on the patient's situation. This is also a patient we had. Again, this is a blunt injury, but something flew and it hit the patient, and it really resulted in complete laryngeal injury. Luckily, the patient was, again, awake, but the airway needs to be secured. But here you can resuscitate the patient, and then you can really plan what to do. Sometimes, all what we needed to do here is just to find where the trachea is and just stick the endotracheal tube directly. But you have to control it. You have to do it in a controlled manner. If the patient was a bit uncooperative here, so as Dr. Mehta said, you can actually do what we call a trial of facilitated cooperation. You facilitate cooperation of the patient by giving him some medications that will make him more cooperative, but you have to do it, again, very appropriately. Otherwise, you'll turn a contained situation into an uncontained situation. So when there's always room for rapid sequence intubation through the usual methods for trauma patients. But you just have to have a plan B and a plan C because it might not always work. And then usually our plan B is to just perform what we call a front of neck access airway, a FONA, or a cricothyroidotomy, usually in the emergency settings, because it's either a cricothyroidotomy or a tracheostomy. But a tracheostomy is not really suitable for For emergency situations, because it needs more planning and it's slower to do, and the access needs a bit more pre-planning. However, cricothyroidotomy, the anatomy is easy. You just identify the thyroid cartilage, it's directly beneath, and you can do it as a life-saving. The area is relatively, I will not say bloodless, but there is nothing major running in that place. So how do you find it? Again, these are some tips. You have to be prepared. It has to be already in the back of your head as a plan B or a plan C, and you have your equipment ready. And I have to say, some of us are surgeons here, but don't be mistaken. This is not something we do every day. So don't think like, oh, I'm not a surgeon, I cannot do it, the surgeons. It's still something that's rarely done, but it's life-saving. Always question yourself, like, if I'm not going to do this, the patient will die. So, if I do it, but there is some bleeding, who cares? We secured the airway, then the bleeding is manageable. And if you do a longitudinal incision, like in the picture on the right, and you stick in the midline, there is nothing major in the midline. No vessel, not even the external jugular is in there. So even if there's bleeding, you can rest assured that it's fine. And if you do a longitudinal incision, the good thing about a longitudinal is that you can extend it. If you think this is the anatomical landmark and you open a longitudinal and you're below or you're higher, then you can extend it up and down. A transverse incision is not really helpful for you. But if you do a longitudinal from up to down, then you know what? If you're slightly higher, you just extend it. If you're slightly lower, you just extend it. You just have to find the cricothyroid membrane, open it, and then stick a bougie, stick an endotracheal tube, tracheostomy, whatever you have. If you have a ready kit, that's even better. Again, you just have to be ready to do these kinds of things. I don't think anyone is an expert in doing surgical airways. No one is going to come say, oh, I do surgical airways every week. I don't think that's a thing, but if you're prepared, I think you will save a life someday. So, this was talked about beautifully, but again, your patient is bleeding most of the time. Your patient is unwell because he just sustained major trauma, so you have to really make sure that they are resuscitated before you take over and you destroy their sympathetic drive with your medications, and you turn their ventilation into positive pressure ventilation, and now the venous return has to fight through the PEEP to go back to the heart, to have a cardiac output, to have a blood pressure. So you really have to make sure that your patient is really properly resuscitated. I know we as trauma surgeons say, never use vasopressors, but if you're going to give medications to take control of the breathing and to do intubation, you might need at least stat doses of vasopressors to maintain the blood pressure because, as I said, hypotension is really bad for head injuries. But, as a surgeon's rule, because we are not really very, very evidence-based, just ballpark it, reduce your induction agent dose by 50%, and just maybe increase the dose of paralytic so that you have more control of the patient. If the patient survives, he will thank you. So some of the guidelines I will not go through, but might be useful to you. The East guidelines for airway securing in trauma patients, and they emphasize the use of RSI. The NAP4 report, which is one of the largest studies that looked at all intubations in the UK, and they have a really prolonged report of what can go wrong and what could go right. And most of the time, it is when people don't use capnography and they don't have difficult airway trolleys and they're not trained for difficult airways is where the complications arise after intubation. There is a difficult airway society. When I was preparing this presentation, I learned about it, and they have actually guidelines that came out in 2018. You may wish to read that too. So you have to have a team. You have to coordinate. You have to prioritize pre-oxygenation, resuscitation. You have to have a backup plan, not just, I will intubate, I will intubate, I will intubate. Most of the time, and at least in trauma airway, the surgical airway is a real possibility as a plan B or a plan C. And always debrief after the event, after each trauma, to see what can you do to improve. So in conclusion, trauma airway is unpredictable, and requires meticulous preparation. We should use structured approaches for these patients. Always have, an algorithm on what to do. And every trauma airway should be considered a difficult airway, whether anatomically or physiologically. Thank you.
Thank you. Now we have 10 minutes time because we finished on time for questions. And can we please have a microphone for the audience? Yes. Well, while somebody is getting ready for a question, Dr. Tamer, let me tell you how the whole blood started in Afghanistan and Iraq. Dr. Holocomb, whom you mentioned, because I know these people personally, I work with them on the Central Committee on Trauma. They started having the walking blood bank. So people would be divided into different blood groups. They would be sitting in the cafeteria, and then there is a call that we need AB positive. So his friends who are screened for HIV and hepatitis would go and give the whole warm blood, and you have shown the advantage of this transfusion. So for us, as you mentioned, in this part of the world here in the region to start adopting it, we have, logistics and we need special permissions, but I think it's a great idea. Back in the 70s, it used to be whole blood, and then the blood bank took over, and now we have to fight it back. Already in the United States, they are working on it. It's just a comment, not a question. Questions? Yes.
I'm Dr. Ahmed Sultan from the Amiri Anesthesia Department and ICU Department. Thank you for the great lectures. I just wanted to ask about what is your endpoints of resuscitation during, for example, intraoperative cardiac arrest due to hypovolemic shock, for example, to avoid what you mentioned, like over-resuscitation. So what is the endpoints of resuscitation to prevent over-resuscitating the patient and complications of transfusions?
This is a question to
the previous lecturer, not the last lecture, the previous one.
Yeah.
Well, I mean, this is endpoints of resuscitation is, who's the, okay. So endpoints of resuscitation is related to your resuscitation practices. You need to keep that in mind, whether related to blood or other than blood. So normally you want to resuscitate to a physiological parameter, whether that is a blood pressure, a lactate. It depends on the situation you're in. It's a combination between the surgeon, the anesthetist. So ultimately, what's the plan? If you're still in the operating room, you need to follow the concept of damage control surgery and damage control resuscitation. You think that the patient has already developed signs, and maybe tomorrow's talk will be more relevant to that, but you find the patient is heading towards developing uncompensated shock, you damage control, you go to the intensive care unit, you resuscitate to, you manage acidosis, acidosis, hypothermia, and coagulopathy, and then once the patient has stabilized, you go back. If the patient is going towards an arrest situation, then you need to identify that and stop at appropriate time related to the injury. I'm not sure if I answered your question appropriately, but...
Okay. Doctor, please.
Assalamu alaikum. Thank you all for your lectures. That they were very informative. So my questions to Dr. Tamer. Maintaining a ratio of 1:1:1, especially in the face of severe shortage of blood products, may be almost impossible to obtain. So is there any rule or evidence that support the early use of recombinant factor 7, especially early, rather than using it in the late stages of refractory hemorrhagic shock, especially when you are faced with massive bleeding?
So again, it's the question is a little bit as a trauma. I'm a trauma surgeon and intensivist, so I look at it from both sides. But the question itself really rubs me the wrong way, Because if the patient needs the blood to be saved, our first response is to the patient, is to the individual. And then second is to the community and to social justice and figuring out the shortage of blood. And so in my head, if I think the patient needs it, I'm going to give it. And then ultimately, if you reach the situation where you think this is futile, then you need to be considering your approach to the patient as a whole. It is very clear from the literature that achieving as close to 1:1 or whole blood is associated with better outcomes and is associated with lower blood component utilization. And so I think really that is the way to go. And it's one of the very few areas in trauma surgery that is supported by a lot of evidence. You're going to get into arguments with the blood bank and with the hematologist. And so in my head, either you're wasting if you start doing 1:2 or 1:4 or whatever, that potentially ends up wasting this amount of blood because it's not being given at the appropriate dose, ends up prolonging the need for blood. So it's clear, evidence is out, you need to do 1:1. Replacing that with factor 7 is very expensive, and there's a lot of literature that shows that it does not really, it's not always effective. And the evidence supporting the blood 1:1 is more than the evidence supporting factor 7. So you're not going to be able to trick your way out of it. The right thing is to give 1:1 or whole blood, and there is no other alternative. Thank you.
More questions? I have a comment to Dr. Ahmad because I was involved in the 11th edition of the ATLS, and you are right. I'm a trauma surgeon, and I agree that C before A is not the great thing. So that's why they're working on calling it XABCDE, which is exsanguinating. Because C, like circulation, any bleeding, as you said, might be dealt with, and we will miss the airway and the patient will die. So they're calling it XABCDE, exsanguinating. It's like amputation, severe blood from the femoral or something where you can apply a tourniquet. But A will always remain a priority. Okay, and one example that I had once, we had a gunshot wound to the neck, and there was bleeding and the trachea was disrupted. So we took an ET tube and we put it in the trachea and the patient lived. She was shot by her husband, but the trachea was transected. And again, in difficult airways, you have to be ready, you have to be, as you said, this was a beautiful lecture on how to be ready, to be prepared, and sometimes to do a surgical procedure to save somebody's life. Questions?
Again, a pet peeve of mine, but even XABC is, I feel if you're addressing the exsanguination, you have made a determination in your head that airway is not a priority anymore. And so it's more of trying to keep the argument alive and keep the discussion going. But even if you have somebody exsanguinating and he's lost his airway, most probably you're going to address the airway right away. And if you're addressing the exsanguination, at some level in your head or in your mind, you've determined that airway is not a priority anymore. So you've gone through the A and the B, although not officially, but you've gone through it and you've decided that what's going to kill this patient now is the exsanguination, and you're addressing the C.
Correct. I'm on your side with this, but next month I'm going to Chicago for the Central Committee on Trauma, and they're issuing this new edition this year, and I'm sure there will be an XABCD. So we can argue, but again, airway will always remain. You know, in ACLS, they say C before A, and they do the perfusion. They stop doing this, whatever, mouth-to-mouth or airway, so C before A. But the issue is airway will always be oxygen delivery. If we play with this, the patient is not in good shape. Please.
Thank you, Dr. George. I think, I think this concept of C before A is because some of us as resuscitation experts, they started really interpreting A as always put intubation. Do intubation for every trauma. We've seen it. Patient bleeding, he's a bit, his GCS is a bit low, and suddenly there is a tube, and now you've turned a hypertensive patient into a patient with arrest. So I think the C before A came for those patients with there is no airway problem. It's just maybe a bit of hypoventilation, or maybe the airway needs to be opened rather than secured. Patient with low GCS and he's snoring, you just need to do maybe just a bit of chin lift or a jaw thrust, insert an oral airway. This is the airway. Airway is done, and now you have to focus on the real life-threatening injuries. But people, we often we find the emergency already intubated the patient, and now he's arresting. Not a single unit of blood has been given yet. So this is where people said, okay, let's put C before A. But now I'm just worried when you put C before A, then the airways I have shown will get mismanaged. Because someone, the ATLS 11 said, do C before A. So now there is a patient with a trachea and it's occluded, or his face is disrupted, and I'm just putting a line trying to get blood. No, here, because if the patient is really hypoxic and the airway is occluded, you have less than minutes even 2 or 3 minutes, there is hypoxic brain injury, and then whatever you have done is useless. But if there is a patient with a stab wound, or a patient with a head injury, but you just need to open the airway a bit and give some ventilation, by all means, go for C before A. Just know what to interpret when you say airway. Airway means really patient needs an airway right now.
Thank you. I cannot agree more with these comments to save lives. Any final question? I have a comment about the Riboa. Thank you for recommending against it. People who had one positive comment, I work with them, are like Tom Scalia, who is the king of trauma, and Eileen Berger, the president of the Committee on Trauma, and Inja. So if you get all these people together, they will say, yes, it is positive. But unless you have a vascular surgeon or an IR person in the ED, which you rarely have, I think it will fail. As you said, you will lose time. And I don't know why they had a study on penetrating injury where you go and put Riboa. So if it's penetrating, not blunt, you need to go to the operating room anyway. So to lose time, to try to inflate a balloon in the infrarenal aorta is easier said than done. And I fully agree, because back at the American University of Beirut, we have it, but we rarely use it. I mean, it's like maybe once a year. Again, like the ER thoracotomy with 99% mortality, you open the chest in the ED, you get a vascular clamp the aorta in the chest. How terrible is this? How many people are trained to do it? Let's start there. So if you're gonna teach something to the surgeons and the ED physicians, we cannot teach them the most complicated thing. And it is a loss of time.
The message has to be, don't waste your time in the emergency room trying to get something for the number to look nice. What you need to do is to give blood and get to control, whether in the OR or outside the OR.
Thank you. This session is over. Thank you for the speakers and the audience. We'll have a half-an-hour break and be here at 10 o'clock sharp.